Hello, my name is Tariq Adar, and today we'll be talking about neurohumoral mechanisms. This is a very high yield aspect of cardiac physiology. You absolutely must know this. It will be tested pharmacologically, it will be tested physiologically, it will be tested pathophysiologically. You need to understand how our body maintains this balance. For the purposes of this lecture, I've cited Richard Klabunde's website. It's called cardiacphysiology.com, and I've put a link to it right here. Or not a link, but I've written out the name of the website right here. If you don't prefer the lecture format and you prefer to just read, that's a very high yield resource. I've tried to take the parts of it that are most pertinent and sort of synthesize it together. And as always, this is for educational purposes only. So there's different categories, and you can kind of put them into two uh, different clumps. You have the neural mechanisms that maintain blood pressure and heart rate and our cardiovascular function, and then you have the hormone or messengers. All right, two different clumps. So the sympathetic nervous system and parasympathetic nervous system. The sympathetic nervous system is going to be, let me get my pen. It's going to be adrenergic. All right. So the sympathetic nervous system uses adrenergic signaling, and the parasympathetic nervous system is going to use cholinergic signaling. All right. And remember, these are the two branches of the autonomic nervous system. All right. The autonomic nervous system. The sympathetic nervous system is going to stimulate the heart and it's going to constrict blood vessels. And the end point of that is to increase blood pressure and increase end organ perfusion. Okay? So that's what the sympathetic nervous system, overall, what its goal is, remember, it's related to your fight or flight. The sympathetic nervous system's goal is to increase that perfusion. Whereas the parasympathetic nervous system is going to depress cardiac function. So that's how you're going to relax. So you can see what the problem would be if you have too much sympathetic nervous system. If you have too much sympathetic nervous system stimulation, like if you're on amphetamines, you can see why that could cause a hypertensive crisis and a lot of the downstream sequela of malignant hypertension. And you can see how overzealous use of parasympathetics can cause depression of cardiovascular function. So those are just two things to keep in mind. And these are all the different hormone signals that we're going to discuss. So the medulla is going to be sort of monitoring all the different inputs that are coming into it from across the body, and we'll talk more about those inputs in a little bit. But the point is, it's going to decide whether blood pressure needs to stay the same, go up, or go down. Think of the parasympathetic nervous system as a brake and the sympathetic nervous system as gas. If blood pressure needs to increase, the medulla will act through the sympathetic pathway where the sympathetic nerves are going to synapse in their sympathetic ganglia, and then neurons from there are going to synapse in the heart and the walls of the blood vessels, causing blood vessels to constrict and for the heart to beat stronger and faster. That's the sympathetic system. But let's say the medulla thinks that the blood pressure is too high. Well, then it's going to signal through the parasympathetic uh, branch of the autonomic nervous system, and that's going to depress cardiac function. All right, so there's this interbalance that's always going on. It's coming from receptors throughout the body, um, and there are inputs that can come from the higher order brain structure, so from the hypothalamus and the thalamus and the cerebral cortex, which is important when responding to our fight or flight. For example, if we perceive a threat, it doesn't matter what the normal baseline for our blood pressure and heart rate would be. The moment we perceive a threat, whether it's physical or psychological, we get that overriding signal, as we're going to see on the next slide, and that's going to make us increase our blood pressure and increase our heart rate. That's why in a panic attack, your heart's beating in your chest, right? Okay. So the parasympathetic nerves, these effector nerves, let me write that out. These effector nerves are primarily under the cranial nerve 10. Okay, parasympathetic vagal. That's cranial nerve 10. This is important. You must know this because this is also going to mediate the effector arm of the reflex arc, of the carotid receptor reflex, which we'll talk about at another time. But you do need to know that cranial nerve 10 is going to be the efferent arm of that reflex arc. Okay? So one thing that I need you to know is that the nucleus tractus solitarius is going to be the components of the medulla that is responsive to signals coming from the peripheral nervous system in the form of baroreceptor signals and chemoreceptor signals. So chemoreceptors are going to be sampling the plasma of the blood for different solutes that are going to require certain things, and we'll talk about those at a later point. And baroreceptors, what they do is they detect stretch. So they're mechanoreceptors that sense stretch. Um, and when they're triggered, they're going to send this information to the nucleus tractus solitarius of the medulla, and it is the nucleus tractus solitarius of the medulla that's ultimately going to lead to either the vagal or sympathetic um, response. Don't worry too much about everything else on here. What I want you to take away from this diagram is that it's the receptor afferents that are providing information to the medulla, and the medulla, under the influence of higher order brain functions, will implement either a sympathetic response or parasympathetic response. That's what I want you to know. What I also want you to know is that this vagal innervation of the heart is not going to really extend to the ventricles. It's mainly going to be the SA node, the AV node, the atria, but it's the sympathetic efferent nerves that are going to be present in the SA node and in the ventricles. Don't worry about which node, etc. The big picture that I want you to take away from that is that there's very little vagal innervation of the ventricles, but there's plenty of sympathetic innervation. And that's going to be important for the concept of contractility. I definitely want you to understand that the SA and AV node are innervated by the vagal nerve, because what the vagal nerve will do is that it can depress the function of those nodes and decrease the heart rate. So again, you really do need to know that cranial nerve 10 is mediating a lot of this. I just mentioned on the other slide, and I'll repeat it now. So I'm going to have a different video going into detail on the renin-angiotensin-aldosterone system, and I would strongly recommend watching that video after this one, but I'm going to try to keep everything very simple for our purposes here. The kidney is going to perceive decreased blood pressure or decreased salt delivery. They're very synonymous. So water goes where salt goes. So when the distal tubule, which is part of the nephron, and it's going to be measuring the amount of salt, therefore, ergo, the amount of fluid, when it when there's low pressure, less salt gets filtered into the kidney. So really, they're measuring the same thing. Those two, not they're measuring the same thing, but those two things go hand in hand. So decreased pressure and decreased salt delivery and increased sympathetic drive that's signaling, hey, blood pressure's low. Those three things are going to cause certain cells in the kidney called juxtaglomerular cells, but don't worry about that right now. Those three signals are going to cause the release of renin. And renin is going to cleave angiotensinogen, which is made in the liver. And it's very important that you know that this is made in the liver. It's going to cleave it into angiotensin 1. And angiotensin 1 is going to be cleaved by some capillaries and mainly by the lungs into angiotensin 2. So this is mainly happening in the lungs. And angiotensin 2 is our big important main character in a sense, because angiotensin 2, first of all, is going to directly act on the brain to cause the release of ADH. That's going to increase the amount of water absorbed in the collecting ducts of the kidney. And you can sort of see how that would balance low blood pressure, right? You're bringing fluid back in. At the same time, fluid on its own isn't enough. You need to bring salt back in. So angiotensin 2 will directly increase the amount of salt reabsorbed in the kidney, and that's what this arrow represents. Additionally, it will signal the adrenal cortex, and the adrenal cortex will then release aldosterone, which is a mineralocorticoid. Aldosterone is a mineralocorticoid because it increases the absorption of the mineral, namely sodium, in the kidney. So it's going to upregulate sodium channels in the kidney, and that's going to give you more salt. So you're going to absorb more salt and more fluid together, and that's going to remedy the situation and increase your blood pressure. So that's one arm of the angiotensin 2 response. It directly increases salt reabsorption. It leads to aldosterone to increase salt reabsorption, and it increases ADH to increase water reabsorption. So that salt and water are being reabsorbed together. And you can see here, there's a second arm that's going to directly increase the systemic vascular resistance. And by directly increasing systemic vascular resistance, angiotensin 2 is going to increase the pressure in the arteries. And because the pressure in the arteries has gone up, blood volume and cardiac output has now gone up. So that represents a feedback loop. And so again, constricting, I've highlighted the really important ones for our purposes here. You constrict the resistance vessels, and by increasing systemic vascular resistance, you're going to increase mean arterial pressure. You're going to increase the blood pressure. By increasing sodium reabsorption, you're going to increase the effective circulating volume, because sodium determines how much fluid is in the blood vessels. So more sodium in the blood vessels means more effective circulating volume, which should increase your blood pressure. And that's the goal of AT2. Remember, it's responding to a low blood pressure signal, and it's a feedback loop that's going to increase blood pressure. Aldosterone is going to be released from the cortex, and again, that's going to increase sodium reabsorption. So angiotensin 2 does it directly through sodium chloride symporters, and it also stimulates aldosterone to do it through epithelial sodium channels. But don't worry about that right now. That's not important at this stage. Let's focus more on the big picture, which is the blood pressure itself. And it's going to cause the posterior pituitary to release arginine vasopressin or antidiuretic hormone. They're the same thing. It just depends on who the author is. Um, but that's going to be released from the posterior pituitary into the hypophyseal portal system, and that's going to drain from the pituitary into the systemic circulation and act on the collecting ducts of the kidney. It's going to stimulate the thirst center. In fact, the thirst reflex is very powerful. And angiotensin 2 will signal thirst, but there's also an inborn thirst reflex, and it's a very powerful reflex. It's very difficult to be dehydrated or have low water content. It's very difficult to do that if you have a source of water. The thirst stimulus is very powerful. If you have water available and you're extremely thirsty, odds are you're going to drink, unless you're purposefully abstaining for like fasting and Ramadan, like I'm doing right now, which is why my voice might be a bit dry. But in a otherwise normal human being doing their day-to-day function, a decrease in the amount of fluid of water is a big red flag. Because if they have an intact thirst reflex, they should not have low water content. I mean, again, we're assuming the person isn't abstaining purposefully, they're not exercising, they're not running a marathon, they're just choosing not to drink water, even in the presence of low water content in the body. You need to probe for neurologic damage to the hypothalamus. Um, that's a red flag. There is no reason, aside from an impaired thirst reflex, that someone should be in that situation. Sorry. All right, so let's get into the medicine. ACE inhibitors. Let's remember that how that pathway went, right? It went renin, angiotensin 1, right? It cleaves angiotensinogen to angiotensin 1. So it would be more accurate to draw it like this. Although we call it RAS, it might look more accurate this way. It's angiotensinogen cleaved by renin into angiotensin 1 and then cleaved by angiotensin converting enzyme into AT2. And AT2 has all those blood pressure raising effects, right? That we're not going to belabor the point. So what you do with an ACE inhibitor like lisinopril, right? Or captopril, all the prils. So lisinopril is an ACE inhibitor that's going to inhibit angiotensin converting enzyme, okay? And when it inhibits angiotensin converting enzyme, you're going to have decreased angiotensin 2 and decreased blood pressure. All right. So that's the reasoning behind lisinopril. And there's also, remember, angiotensin 2 has its targets. Well, there are also pharmaceuticals that target the targets of angiotensin 2, those receptors, the angiotensin 2 type 1 receptors. And those are blocked by drugs like valsartan. And those are called angiotensin receptor blockers. They're called ARBs. All right. And that's opposed to drugs like lisinopril that are going to block ACE. Okay, so one is more downstream. This one's acting more downstream. This one is acting more downstream of the ACE inhibitors. And the reason why sometimes we use ARB is because the first line is the ACE inhibitor, usually. And one of the contraindications of the ACE inhibitor and therefore switching to the ARB, the angiotensin receptor blocker, is the development of cough or angioedema. All right, and the two things are related. Okay, angioedema is this widespread swelling of of uh, of blood vessels, and the cough is a cough. Now, the ACE inhibitor cough is somewhat notorious. About 15% of patients on an ACE inhibitor will develop the ACE inhibitor cough, and that's going to necessitate a switch to a different medication if it's distressing the patient. Because ACE not only leads to the production of angiotensin 2, it's going to be involved in forming bradykinin. Okay? This is important. You must know this. It's involved in breaking down something that breaks down bradykinin. Okay? So normally, so I put ACE here. Yeah, it's going to lead to increased angiotensin 2 and decreased bradykinin normally. All right. When you inhibit ACE, one of your goals is going to be to decrease the angiotensin 2, right? Okay, and that's good. That's our therapeutic effect. But what's also going to happen is increased of this pathway, this bradykinin pathway. I'm not going to go into detail of all the metabolites right now. Bradykinin. And when bradykinin increases, that's what causes swelling. That's what causes the cough. So that's just something for you to keep in mind. All right, and now we're going to talk about renal artery stenosis. So let's say if this was the renal artery, that we started to narrow it, okay? What would happen next? Well, first of all, the afferent arteriole, which feeds off of it, is going to have decreased blood flow. So you have decreased renal blood flow, okay? Decreased renal blood flow. And that's going to correspond to decreased filtration in the glomerulus, okay? Less blood flow means less filtration. And this decreased blood flow is going to lead to decreased sodium delivery and a perception of decreased blood pressure. Okay? So what's going to happen? We're going to have renin signaling. And the consequence of that, first of all, it's not good for the kidney. Renal artery stenosis is not good for the kidney itself. But above that, beyond that as well, you're going to have this permanent upregulation of renin that you could give as many ACE inhibitors as you want. It's not going to do a thing. Like a lot of your well, I don't want to say it's not going to do a thing. It can help, but the broader issue here is that you have a renal artery that is stenosed, and as long as it is stenosed, there's going to be decreased blood flow. So what happens is you try treating hypertension in so many different ways, but the blood pressure of your patient never comes down. So that's called refractory hypertension. Refractory hypertension. In refractory hypertension, you're administering antihypertensive medications, but the blood pressure isn't coming back down. And the only way and that should really cue you to look for renal artery stenosis. So in a patient who has had multiple different hypertensive treatments, whose hypertension just fails to respond, you should look at the renal blood flow, and you're going to assess for renal artery stenosis. And if you can confirm that stenosis on imaging, what you're going to do is you're going to place a stent. And that stent is going to open that renal artery back up, and that's going to fix the renal blood flow issue. It's going to fix the filtration issue. It's going to fix the issue with the sodium delivery, and that's going to decrease the renin signaling, and that should fix the blood pressure. So remember, downstream of angiotensin 2 is going to be aldosterone. All right? So in primary hyperaldosteronism, this is divorced. There is no angiotensin 2 is not necessary for aldosterone to be released. Aldosterone is just permanently on the go. And this is a very common cause of non-essential hypertension or idiopathic hypertension. So like 90% of all hypertension is just I don't want to say physiologic, but doesn't have some major organ system cause. One of the most common major organ system causes of hypertension is going to be primary hyperaldosteronism. So the adrenal glands are going to be just making aldosterone like crazy, and that's going to lead to permanent increased sodium reabsorption. And as a result of that, you're going to have permanent, or not permanent, but you're going to have elevated blood pressure. So I have a question for you guys. So can you use an ACE inhibitor to treat primary hyperaldosteronism? No, you can't. And as you can see, angiotensin 1 is converted into angiotensin 2 by ACE, and it's angiotensin 2 that then acts on the adrenal cortex to cause the release of aldosterone. However, in the case of primary hyperaldosteronism, this is happening regardless. So it doesn't matter how much ACE inhibitors you give, that hypertension isn't going to be fixed because this is not the issue. This is the issue. In primary hyperaldosteronism, this doesn't matter. It's an adrenal process. All right? So again, refractory hypertension, you want to think renal artery stenosis. You want to think primary hyperaldosteronism if it's refractory to ACE inhibitors. It's a very common cause of hypertension. All right. So you can also target the aldosterone receptor. So let's say somebody has primary hyperaldosteronism, you want to bind the aldosterone receptor. So you can see here the aldosterone upregulates ENaC function. So sodium is reabsorbed from the tubule back into the interstitium. So in other words, it's not allowed to be peed out. All of this is going to be urinated. So what happens is aldosterone will drag the sodium out of the urine and water will be dragged with it. All right, but that comes at a cost because you have to follow the laws of chemistry. Because note here, sodium and chloride are exchanged for sodium and potassium are exchanged for two chlorides. One sodium is exchanged for one chloride. Here, you're just losing positive charge from the urine. So positive charge has to come into the urine, and that's what the potassium and hydrogen do. But in again, focusing on big picture, if somebody has primary hyperaldosteronism, you can use an aldosterone specific antagonist, all right? And those are called potassium sparing diuretics because they block this sodium reabsorption process that tends to have you lose potassium. So you're spared the loss of potassium by using that diuretic, all right? And that can be used to treat primary hyperaldosteronism when ACE inhibitors can't. So I want to give you an overall view of the Frank-Starling mechanism that's very basic. I'll talk about it more later. But basically, I want you to think of muscle cells as like a spring. I want you to think of the heart as like a spring, okay? And the more you stretch it, the stronger it contracts. So if it's stretched this much, it's going to contract stronger than if you stretched it this much. All right, this is going to cause it stronger. There's more stretch, so there's more fluid in the heart. There's more stretch, and the heart muscles contract more strongly. that stretching promotes the amount of actin, and it increases the crossing area for actin and myosin, so you can form more powerful contractions. And decreased stretch means there's less area for interaction for actin and myosin, and that's going to decrease the strength of the contraction. So that's called the Frank-Starling mechanism. It's really important. You have to know it, and we'll talk about it more later. But when you have less, so let's say I administer all these diuretics that are trying to reduce fluid. So let's say we're getting this person to pee out a bunch of fluid. The end result of that is because the fluid's being peed out, it's not coming back in the veins. So you have decreased fluid coming back in the veins, and decreased fluid in the veins is going to lead to decreased fluid in the heart. So decreased fluid in the veins means decreased fluid returning to the heart. And decreased fluid in the heart means you have decreased preload. That's sort of what we call preload. Preload is the amount of fluid in the heart. It's how much volume the heart is going to need to contract and clear. So this decrease in preload is going to directly, because of the Frank-Starling mechanism, because there's less fluid, the heart does not contract as strongly, and that's going to decrease both the stroke volume, and by extension, it's going to decrease the cardiac output, and that's going to reduce mean arterial pressure. All right, so that's the reasoning behind the use of these diuretics. And you can see why they'd be important in a patient with congestive heart failure, because you want to decrease the amount that they need to output. You want to decrease their cardiac output because they're overwhelmed with fluid. The preload is too much for them, and it's increasing the demands on their heart, which is going to damage the heart, especially a heart that can't properly respond. So you give them a diuretic, so you lose fluid in the veins. That means there's less fluid in the heart. That decreases the preload, and the contractions are less powerful. And it's a tricky slope, because you don't want to absolutely obliterate someone's preload and they become systemically hypotensive. That's bad. So you want to play this balancing act of giving and you can also hurt the kidneys, because remember, the kidney doesn't like to perceive low blood pressure. So you want to be careful, and you're playing a balancing game, but at the root of it is the Frank-Starling mechanism. So big picture, there are a couple of things that are going to regulate the release of arginine vasopressin. First of all, any situation of severe volume depletion. Severe volume depletion. All right, so we're talking about hemorrhage. If you've been in the desert for God knows how long, um, there's a yeah, big things, because it takes a very high level of ADH or vasopressin. Remember, they're the same thing. It takes a very high level of that to cause that blood vessel constriction event. However, it's important in things like hemorrhage. All right, so there's specialized stretch receptors in the wall within the walls of the atria and in the large veins. They're called cardiopulmonary baroreceptors. And those stretch receptors are going to decrease their firing rate when there's a fall in atrial pressure. So as the atrial pressure becomes less and less, there's less stretch of these receptors, these cardiopulmonary pressure receptors, baroreceptors. And that decrease in the receptor firing, it says atrial here, but it's atrial and cardiopulmonary, that decreased firing is going to signal a fall in atrial blood pressure. All right, so that's going to synapse in the nucleus tractus solitarius of the medulla, et cetera, et cetera. There's going to be some overarching controls coming from the cortex, cerebral cortex, and the hypothalamus. We already talked about that. But that's one arm that you need to be familiar with, because what will happen is that separate of what we discussed earlier, we talked about how you have these baroreceptors and how they're talking to the medulla, and the medulla is working with the autonomic nervous system. There's a second arm of that response where the medulla is going to directly talk to the hypothalamus, and the hypothalamus is going to cause the release of AVP from the pituitary. Remember, the hypothalamus is what regulates the pituitary gland. So, but when there's decreased baroreceptor firing, the hypothalamus is going to increase the signal for the posterior pituitary to release its vasopressin. And at very high concentrations, that's going to cause blood vessel constriction. That's important for things like hemorrhage. But that's the V1 response. And the V2 response, and those are the name of the receptors, the V1 versus the V2 receptors. The V2 response, which is the more common one and the one we see more physiologically, and that's going to be the reabsorption of water in the kidneys, in the collecting duct. So there's going to be more aquaporins inserted into the collecting duct, and that's going to bring water back in and increase the blood volume and increase the arterial pressure. Like we said, angiotensin II can directly stimulate the hypothalamus for the secretion of vasopressin. And here again, we see sympathetic drive. The same way it can directly trigger renin, it can directly trigger vasopressin. And high osmolarity, so high concentrations of sodium indicate low concentrations of water, or a low, not concentration, a low amount of total water. So that's going to be a direct stimulus, not just for vasopressin. This hyperosmolarity will also trigger the thirst reflex. And remember what we discussed about that. So there's a system that's responding to low amounts of fluid and low baroreceptors, and that was renin, angiotensin, aldosterone, etc., arginine, vasopressin, the nervous system and parasympathetic nervous system. We've talked about all these things. Now let's talk about some hormones that are going to try to reduce water or fluid, effective circulating volume in the blood. Atrial natriuretic peptide and brain natriuretic peptide, I'm going to just call them the natriuretic peptides. First of all, they directly offend renin. They decrease renin signaling, so they put an end to that cascade, or they try to, but eventually they can't. If there's enough angiotensin signaling, they can't fully overcome it. Over here, you can see that angiotensin 2 is actually a trigger for the natriuretic peptides. So that represents a negative feedback loop where the product of the RAS system, angiotensin 2, will increase the expression of its own inhibitor. That way your blood pressure doesn't skyrocket, right? You want to increase blood pressure, but with these natriuretic peptides, you keep it within reasonable limits, right? You get your increase, but it's within reasonable limits. In congestive heart failure patients, it's blown out of proportion. Similarly, when you have sympathetic drive, that's a pro blood pressure state, and that's going to directly lead to the natriuretic peptides being released. And again, that's a negative feedback loop because they're going to counteract that blood pressure increase. If the heart is directly distended, that's going to cause increases in the natriuretic peptides. And so like we said, that's why I want you to think about its effects on blocking renin and increasing the glomerular filtration rate. It's trying to get more fluid and water and salts into the urine so that the blood volume decreases, so you can decrease blood pressure. But another arm of that is that they can directly vasodilate. And vasodilation is promoted by the formation of cyclic GMP. So there's a couple other signals that are going to be associated with cyclic GMP, and that's going to cause smooth muscle relaxation and vasodilation. But the natriuretic peptide receptor, the NPR receptor, is associated with guanyl cyclase, and that's going to change GTP into cyclic GMP, and that's going to be the second messenger that sets off its whole cascade. And there's an inhibitor that breaks these down. All right, it's called neprilysin. So neprilysin breaks down the natriuretic peptides. So there's actually a neprilysin inhibitor available. It's called sacubitril. And what that does, and we use it to treat congestive heart failure, and what sacubitril does is that by inhibiting, the action of neprilysin, it preserves the natriuretic peptides that are going to be counteracting this fluid overload state, right? There's a fluid overload state, and you want natriuretic peptides, but neprilysin is breaking them down. So you administer sacubitril to prevent neprilysin from breaking down the natriuretic peptides. So this is super important. I promise you, you will see some form of this on multiple exams. All right. You will see up and down arrows, and they'll say which of the following parameters are going to be changed in this way, etc. So draw up and down arrows for what you'd expect in the serum of a congestive heart failure patient. All right. So in a heart failure patient, is the blood volume up or down? Congestive heart failure. Blood volume up. You have volume overload. However, is the heart actually pumping correctly? No. So does the kidney perceive that fluid is coming to it? No. So is it going to increase renin? Yes. So even though the blood volume is high, the kidney does not, the heart isn't beating strong enough for the kidney to perceive that the blood volume is high. All right, so it's going to release renin. And if renin is released, you're going to have high angiotensin 2. And because you have high, not only because you have high angiotensin 2, but because you have increased blood volume and therefore increased distension of the heart, you're going to have increased ANP and BNP. All right. So what about a patient in hemorrhagic shock? Is the blood volume low or high? Low. So is the renin going to be up or down? Up. Because in this case, the kidney is correctly perceiving that there's no perfusion. All right, in the first example, in congestive heart failure, the heart is beating so ineffectively that the perfusion pressure is down, and the kidney's like, ah, my God, nothing's beating. Let me try to help the heart out. Let me make renin. But it's counterintuitive because it's making the renin. It's you have this heart that is in failure, and it's just bringing more and more salt into the heart. So in hemorrhage, however, you have decreased blood volume because you're bleeding out. And that's going to increase renin. And that's going to increase angiotensin 2. Are you going to have increased ANP and BNP? Absolutely not. All right? Absolutely not. Because you are in hemorrhagic shock. You have no fluid. Not no fluid. You'd be dead if you had no fluid. But you don't have enough. All right. And for hemorrhagic shock, is AVP going to be increased or decreased? Increased. Because that level of hypotension is severe enough to get that V1 response, that vasoconstrictor response from ADH that happens in extreme situations like hemorrhage. So endothelium is always synthesizing endothelin 1. So here you have the precursor called big endothelin 1. The guy who named it was very creative. And the endothelin converting enzyme is going to break it down into endothelin 1. Now, endothelin 1 is going to act through the GQ pathway and convert phosphatidylinositol phosphate into IP3, inositol trisphosphate. And that leads to vascular smooth muscle contraction. That's important and you must know it. Endothelin is going to lead to vascular smooth muscle contraction. However, endothelin also acts on it has a B type receptor and an A type receptor, and the contraction is the A type receptor. But once the endothelium releases endothelin, it acts back on the endothelium, because remember, you have the endothelial layer and then you have the smooth muscle layer, okay? And the endothelial layer is communicating with the smooth muscle layer. So with endothelin, the endothelium tells the vascular smooth muscles to contract, all right? But what it also does is it signals to itself that it needs to create nitric oxide. Why? Because first of all, nitric oxide inhibits the production of endothelin, but it also increases cyclic GMP in the vascular smooth muscle. And as we talked about with the natriuretic peptides, increased cyclic GMP causes relaxation of smooth muscle. All right? So endothelin 1 is going to cause contraction of vascular smooth muscle. It's important, you must know this, because damage to the endothelium disrupts this pathway. Damage to the endothelium disrupts the nitric oxide pathway, and it increases this ETA signaling, and it increases contraction. All right? That's important. All right. And we have circulating catecholamines. So epinephrine, epi, is going to come from the adrenal medulla. So what happens is you have preganglionic sympathetic nerves, okay? They synapse in the medulla, and that happens during times of stress, exercise, hemorrhage, etc. It's sympathetic drive, and that leads to epinephrine release. All right, and that's 80% of what's coming out of the medulla. All right, and the other 20% is norepinephrine. All right. However, the major source of norepinephrine, the major source of the norepinephrine is going to be from the sympathetic nerves that are in the blood vessels. So the vasculature is also going to make norepinephrine. And normally, most of the norepinephrine released by the sympathetic nerves is reabsorbed. So it gets released and then it comes back in. But at times of high sympathetic drive, you just have so much norepinephrine entering the body. All right. So as you can see here, you administer the epinephrine and you see this range for the blood pressure slightly goes up and comes back down, and the mean stays more or less the same. So epinephrine isn't majorly affecting the arterial pressure. What it does affect is the heart rate. As you can see, that's coming up, and that's its first effect, and then sort of comes back down. More importantly, it's going to act on beta 1 receptors, adrenal receptors, and increase heart contractility. Okay? So epinephrine's main mechanism of action is going to be by acting on beta-1 adrenoreceptors in the heart and increasing contractility. That's called inotropy, right? Inotropy is increased contractility. All right, and it also has an alpha response. It's going to increase the constriction of vessels as well. All right, um, that's sort of all I want you to know for now. There's some other stuff, but the big picture I want you to know is that it increases cardiac inotropy and it also transiently increases the heart rate. All right, and through its alpha signaling, it can increase vessel constriction, but only at very high concentrations, and we'll see that at the next slide. All right, so as you can see here, the epinephrine's gonna have a beta response, right? But as the concentration gets higher and higher and higher, it gets a dominant alpha response, okay? So epinephrine, unlike norepinephrine, is going to be beta selective, all right? So you don't get the systemic vascular resistance increase that you would see with norepinephrine until there's enough epinephrine in your system to activate the alpha receptors. And that leads me sort of a point that I want to bring up. There can be tumors of the adrenal medulla. You can have a tumor of the adrenal medulla, and those are called pheochromocytomas. They're called pheochromocytomas. Those are tumors of the adrenal medulla because they're tumors. Chromocytoma. So a pheochromocytoma is going to cause very elevated um, release of these catecholamines. And that can cause, and remember, we're talking about their effect on blood pressure and their vasoconstrictive properties and their inotropic properties. Um, that's bad because you can overwhelm the heart, you can overwhelm the vasculature, and you can get malignant hypertension and die. Malignant hypertension. And so this pheochromocytoma is a tumor of the adrenal medulla. It's going to increase a bunch of catecholamines because of epinephrine. And remember, the epinephrine is going to be at a really high dose. So it's going to have its beta and alpha activation because it's coming from a tumor, a lot of epinephrine. So you're going to have hypertension from the epinephrine, and you're going to have increased heart contractility and heart rate from the epinephrine. And from the norepinephrine, you're going to have very increased blood pressure, and that's what causes the malignant hypertension. So pheochromocytoma, it's important for you to know that it is a tumor of the adrenal medulla. It's going to increase these catecholamines, and a consequence of that can be malignant hypertension. When we look at norepinephrine, what do you see? You see a transient increase in heart rate and then it comes back down. But what you mainly see is the blood pressure jumps up. Remember, for epinephrine, this line stayed the same and even went down a little bit. All right? In norepinephrine, the mean arterial pressure does actually increase. All right? You do have this increase. And that's because norepinephrine um, is not going to be as selective. So epinephrine is beta receptive, so the effects are mainly on the heart's contractility and its heart rate to an extent, whereas norepinephrine is non-selective. So it's going to get that alpha receptor response even at low concentrations, and it's going to um, happen immediately. All right. And this heart rate's going to come back down. So it goes up a little bit, but then it comes back down. Why? Because the arterial pressure went up by so much. Because norepinephrine is non-selective, the blood pressure goes up. If the blood pressure goes up, there's more stretch of the carotid baroreceptors. So increased stretch of baroreceptors, and that signaling goes to the medulla, and that's going to activate the cardio-inhibitory center. That's going to increase vagal tone. And when you increase vagal tone, you're going to decrease sinoatrial conduction, and that leads to a decreased heart rate. So this decreased heart rate is a result of the baroreflex. Because norepinephrine is non-selective, it increases blood. Because norepinephrine is non-selective, it directly increases blood pressure. This direct increase in blood pressure causes the receptors in the carotids and the cardiopulmonary receptors to detect more stretch. That increased stretch is going to lead to, it's going to be communicated to the medulla, the nucleus tractus solitarius. That's going to cause enhance the function of the cardio-inhibitory center elsewhere in the brain. That's going to increase the amount of vagal tone, and that increase in vagal tone is going to decrease conduction to the sinoatrial node, and that's going to decrease the heart rate. And that's also part of why you see this blood pressure come back down. That represents the decrease in heart rate. All right, so as this blood pressure comes up, the heart rate comes down. And then as the blood pressure comes down, the heart rate starts to come back up. And that's to prevent a hypertensive crisis.